This is leading well to the concept of patient selection. We discussed this morning about how to select borderline or not. I think the key considerations here are, of course, the surgical resectability, we'll go through that, but also the medical operability, because sometimes we are selecting patient up front without considering the risk of postoperative complication regardless. So this is the just published ERS, ESTS, and ESTRO endorsed guidelines on fitness for curative intent. And I'm glad that with Corinne Favrefin, we were looking specifically at the patient-reported outcome subgroup. And for the first time, you can see that in this algorithm is considering patients' value one of the key aspects here, of course, after the MDT discussion. So it's to give more empowerment, of course, at the MDT, but also to the patient perspective. That is something that we touch in all the conversation this morning as well. So resectability criteria, we had a few efforts in trying to define the resectable and not. This is the ORTC consensus, and you can see that, of course, the N2 bulky, so it's around the N2 the main problem of definition. The STS, so Society of Thoracic Surgeons, has done more or less the same, and again, even among only surgeons, the potentially resectable and the N2 single or multistation is one of the key aspects, not completely clear. So I think it's not easy to see, but Sanjay knows this paper. So the third consideration that we didn't touch essentially is how the regulatory aspects are also influencing the selection of patients. So we have in UK different, so NICE is approving different way of EMA, and so the selection criteria for the reimbursement is in any case affecting the MDT discussion in real world cases, so just to mention here. So in details, a little bit more on the surgical controversies that we are trying to define also in the surgical meetings. So surgical complexities, we had the first report from the NeoStar trials patients. So we had almost 40% of patients that were judged as more complex during the resection. Again, real-world data from Leeds, those were data presented last year at ELCC. Similar percentage, 50% deemed more complex. Interestingly, we had this scoring system where the absence of nodal response and N2 and the PD-L1 more than 50% as risk factors for more complicated operation intraoperatively. This is very interesting, again, from MD Anderson. These are only patients that underwent chemotherapy, neoadjuvant chemotherapy. And as you can see, the reduction of 30% on the nodal volume was associated to more complex maneuver, but also the N1 disease essentially was judged more difficult compared to the N2 one. So some of these data may be reassuring, some of them are a little bit more worrying for surgeons. And the N2 debate is, of course, as we've seen before in terms of surgical complexity, is also in terms of indication. And here you can see that the NCCN and the ESMO guidelines, they have similar consideration in terms of N2. And again, the STS guidelines are also considering a single station N2 as resectable after neoadjuvant. I put here this very nice review from Mariana Brandao and the ORTC group, because I think it's clear that the proportion of N2 disease across those trials is varying a lot, and the proportion of multistation is also very, very more or less not the same. But it's good to know that in this meta-analysis, the EFS after immunochemotherapy is better across the 3 groups, especially the N2 single station and the multi-station. I really like this very recently published paper in Nature of the Checkmate 770 on the N2 analysis, again confirming the N2 disease is favoring the EFS of the N2 disease. But again, if you're going to see the PCR and the major pathologic response on the single station, this is even better when you're looking at the multi-station N2. And for the surgical colleagues, if you're going to the supplementary files of the paper, it's also very interesting to see that the surgical outcomes are reassuring for the stage 3 and 2. So with 80% of patients in the Nivo arm going to have a simple lobectomy. And when you look at the pneumonectomy rate, is again 40% compared to 1 in the placebo arm compared to 1% in the Nivo arm for the N2 disease. Same very reassuring results in terms of definitive surgery, and I think it's also important at some point to consider the patients who are able to continue the adjuvant treatment. And I think that the ETOP-ADOPT trial will also give a little bit more of answers in this sense on what's happening to the N2 patients after neoadjuvant therapy. So these are also the LEADS data so real-world data on the N2 disease patients. And as you can see again, the multi-station, the PCR are even higher. So again, giving some signals in this sense. Extent of resection, a little bit on the pneumonectomy side, reassuring data on the real world compared to the 816, so 40%, 4% compared to the 16%. And again, I think here is about consideration on what Federico has just mentioned in terms, can immunotherapy and chemo decrease the need of pneumonectomy? This is what 816 is reporting, Nivo versus placebo, so 17 versus 30%. And again, I'm biased, but I think that also patient-reported outcomes, so quality of life consideration along those treatment is very important. I think here in that graph, it's very important to see that 816 was reporting the drop immediately after surgery. That is something that we are expecting in our patient, but the Nivo arm was not worse than the placebo. And what has been presented last year with the 770, I think is also a little bit more reassuring in terms of long-term results, because as you can see, the time to deterioration of the lung cancer symptoms is longer in the Nivo arm, so suggesting that it's not affecting in a different way the N2 subgroup. And this is what essentially Federico just presented, but I want to mention what Martin has presented recently, because some of these probably answers are also coming from the MDT bridge in terms of defining resectable, but also evaluating the resectability at some point, and again, great results. I think in terms of also the border, having 85% of patients who were judged borderline resectable to be resectable is a very important results, and of course, a lot of longer follow-up, and again, more patient preferences and quality of life expected, but these are very, very good signals that I think surgeons need to take into account. Just a mention of the EORTC stage 3 platform within the EORTC, Anne-Marie Dingmans and Mariana Brandau, again, just to have a real-world consideration, and we really would like to investigate the patient preferences and also potentially healthcare professionals' preferences in making this decision in a real-world setting. Last, very quick mention, of course, in what I really, really care about, and I think that all of you care at the end of every single day. It's the surgical toxicity, tolerability, and quality of life. This is a recent meta-analysis that we've done in terms of looking at the perioperative settings and see how the quality of life was reported or investigated. And unfortunately, there is this gap around surgery. So how can we define how the surgical complications are affecting patient quality of life, how this decision is affecting the adjuvant attrition, and potentially also the pre-surgical window, because at the beginning you've seen that we have this patient decision that is not yet clear. So we've done a little bit of cross-sectional assessment, and the psychological distress after neoadjuvant in real-world setting is still very, very similar. So with nevo and upfront surgery, so we were reassured. But I think that we are missing the how to blend the toxicity and the surgical complication into this continuum of care. So we have, of course, Dr. Naidu is doing a great job in terms of assessing toxicity, but we are still missing a little bit of recording of the surgical complication and how this can be reported in the trials. And potentially, these are some projects within the RTC in terms of how the criteria of quality of life can affect, for example, patient decision to carry on with the preoperative setting. This is because when we look at the patient shared decision-making, the decisional conflict, for example, in early stage, so we reported essentially that the patient who were offered the SBRT, this is more in the very early stage, but borderline patients, the patient didn't feel that was offered another alternative. So I think we are missing a little bit of patient involvement in this decision. So in conclusion, I think that those 4 pillars are back to the 3 important concepts. So first of all, optimizing and personalizing patients' pathway, potentially rehabilitation. Rehabilitation in general has a great role before and after surgery. For surgeons, we need to be prepared. So I didn't mention about VATS or non-minimal invasive because I think it's more broader. So, and of course, we need to be prepared in terms of lower probably threshold for conversion, and robotic surgery probably can help in this. But the long-term MDT collaboration, as the MDT bridge has already demonstrated, is very important. I'll leave with this slide, which is very interesting because it's something that some of you, again, Sanjay was involved as well. I think that when we ask essentially the surgeons and the oncologists to self-refer essentially in the setting of early stage, but also locally advanced stages. And as you can see, we are still not agreeing even for ourselves, and because probably what the patient is often asking about, so what would you do if you were me, I think we need to collaborate more and more for each individual patient. So thank you so much.